Stacey holds the research chair in knowledge translation to patients at the University of Ottawa, and she leads the Cochrane Review of Patient Decision Aids. So I'll turn it over to Dawn.
So thank you to the presenters, and especially for doing the 20 slides in 20 seconds. Very impressive. So I'm going to talk a little bit about the patient-first part of the playbook and sort of emphasize the different pieces of the 4 presentations. And so I think always it's nice having a patient or a patient collaborator start and really help ground us in how important it is to be thinking about the patient experience. And Anita, it was really amazing to hear your story and how positive your experience has been as being a patient with dealing with mental health battles, but then being able to be part of research teams and really helping ensure that we're working with people like you to try and improve the quality of our research and improvement of the programs, and also community-based research, which you also talked about. And to me, it's a win-win, because you talked a lot about your benefits, but also we're, as researchers, also benefiting from you on the team. Manpreet, so one of the things that I really appreciated what you talked about is really the value of qualitative research and helping us really understand the patient's perspectives that we need to be thinking about as we move forward with building programs that really support patients to become more physically active or in different ways. And I think that's one of the advantages of conducting qualitative research, is it really helps us get a more deeper understanding that we can then use for programs. And Sabrina, in your presentation, you talked about how we gather all this data from patients all the time, patient-reported outcomes, but one of the things that was really important is that it's being fed back into the system and being able to be used for informing programs, but also informing patient care in clinical practice. And I think that's really critical when we're collecting all this data, that we're not just collecting it to sort of fill a need to tick the box that we've collected the data, but we're actually also using it in practice. And Mario and Lillian, it was nice having the pair of you up there, because really demonstrated the partnership. And Mario, you're one of those rare groups of people that is involved in research, because we often question how far we can go when we're working with more frail, more seriously ill, or people with cognitive effects from their illnesses. And so I think that you really demonstrated how it's really still important to reach out and work with even those more difficult people and populations, and the value of you being part of the team and looking at, and the robot as well. Is the robot with us today?
Dementia patients.
Thanks for that question. I think what Peril is different from other animals around, like the cat and the dog that we probably have seen in long-term care they use, it's the sophistications. So it has the proactive and reactive mode with the AI. So it has its way to, it has multiple sensors. So it's able to, if you're just having the robot there quiet, it will has the proactive mode, try to get you to engage you to work with it. And when you talk, because of the voice sensor, it will turn to you and open the big eyes and makes you feel that the robot is listening to you. And I think that's one of the ways why people love talking to the robot, because how it react and respond to you. Yeah. And it also has the machine learning. When you work with it over time, it remembers you. And at the hospital, that the patients that we have, they gave the robot a name called Casper. So once they keep calling him the same name, and he knows that his name is Casper, and then he returns. It's kind of like the pet that we have. You give it a name, and you know that's his name. Yeah.
Thank you.
Lillian, just a follow-up question regarding that as well. Does the robot also speak other languages?
The robot actually doesn't speak any languages at all. So it only coos. It goes, It's like a baby. So in a way, it's good that it doesn't speak any language because it makes it universal. Because here in Vancouver, it's very multicultural, and it's been used in all over the world for over a decade of time. So it doesn't speak any language, so it applies to, this morning we just have family partner come in to do data collections, and so we have a Chinese lady who speaks Chinese, and it doesn't really matter what language you speak. The robot opens its eyes and kind of look at you, want you to talk, and then you can talk to the robot with any kind of languages.
The robot does not have a video also, so to protect the privacy of the patients, there is no actual video on it.
Yeah, that's an important point, because some people worry about when you video them, then, that sense of like my data, right?
Sorry, just to follow on that question, you just mentioned the machine learning of the robot. So I'd like to know next how the data is being collected for the machine learning. Machine learning, my understanding is the robot can adapt into the person it comes to interact with, right? So over the time, it can become so AI intelligent. So how this machine learning actually is taking place for this robot?
I'm afraid I can't answer the questions. I'm not an engineer. So I don't know. I will have to consult engineers, and I don't know.
I think what it is basically the robot reacts to the feelings of the person. So there will be sensors on the flippers and in the back, and also once it acclimatizes your voice, it will, once it hears your voice, it will look up at you and more like it's supposed to be reactive to your emotion kind of thing.
So I think we have time for maybe a couple more questions. So one here.
Thank you. Thank you, Mario and Anita, for bringing the patient perspective to us today. Both of you sounded like you have opportunities with research teams where you feel valued and that your engagement is meaningful. And I'm wondering if there's particular strategies that you can suggest to our researchers in the room around how we make engagement meaningful for our patient partners.
Hi, that's a great question. I think when you have a patient partner come on your projects or on your committees, you have to remember we don't know anyone in the room, right? You recognize people across the table, and I've had this, all the committees I've been on, I've had this many times. People might not know everyone by face, but because they work in the same hospital system or at UBC or Providence Healthcare or VCH, they recognize that. And so we are coming in cold turkey kind of thing. So providing that context, I think it's also really important that you have a conversation before the patient even gets in the room. Explain to them all the things that are involved in that particular project, and also as nurses and as medical people, you all have your own language, and me coming in, I won't understand all your language. So it's being mindful of the language you use in the room, or if you do say something, that you do take that second and address what it is, because I can't keep putting up my hand. And I've been on committees where I'm always putting up my hand going, what does that mean? How does this relate to what we're talking about? So making that a little bit more seamless, taking the preparation ahead of time before you get someone in the room will really benefit you as a team.
A very quick answer to that is use plain English when you write your consent forms and the way you explain what the research is all about. And please try to reduce the acronyms that you use in there, because acronyms, they just go by and then people forget about it.
I think we have one more question in the center of the room here.
Just want to quickly say thank you to all the presenters. The one that really stuck out to me was the research with Paro and the patients with dementia. Just because of my workplace in critical care, we have a lot of patients who experience delirium, and I'm very curious to see if there's been any use from what you guys know about with Paro and on delirium, patients who are experiencing delirium. And also, do you have to be verbal for the PARO to be able to understand you, or is there anything more to that AI?
Dawn to come and provide her response to the presentations, and this time we'll have her stand up in the light so you can actually see her. Thank you.
So thank you very much for another excellent round of presentations that really, again, put emphasis on the value of the patient's voice, the patient's role in terms of influencing our research. Carolyn, there you are. Again, it was very nice starting with a presentation from you around your experience with tragedy, but I think one of the things you pointed out really clearly is that when tragedies happen in the healthcare system, it has a huge impact on the family, but also on us as healthcare professionals, and we need to be thinking about how do we support both in these situations. But then, how do we build that trust, and trust of the patients and families in the healthcare system, but also a mutual trust you talked about, and we need to be thinking about that. And that we can't just assume that it's going to happen. But I think when tragedy occurs, in situations that you talked about with your husband, I think it's a huge opportunity for us to learn as well. Jessica, where's Jessica? Around the sharing of the voices and the experiences, which is really critical, but also you came from, as a graduate of the program, and then coming into the community and being able to work in your community role back with researchers and helping evaluate and bring forward the voice of the patients. But one of the things that I took home most is that need to really tailor to the population and reinforcing what are the key elements of each population. You talked about things like the value of the group in this situation and the predictability of the planning, and being able to work with the different people that you're serving in terms of building programs that suit their needs. Henry, it's amazing seeing someone in third year of the nursing program already is embraced in nursing research as you are, but really valuing, again, through photo voice, but the voice of the patient, and helping us help them articulate their voices through photo, and being able to communicate issues around suicide, one of those topics that we don't usually talk about, but it's really allowing that door to open and share their experiences. And one of the things that you also talked about is the consent and being able to use the information and the sensitivities around ethics when we're collecting this type of data, that we also need to be paying attention to, and also the value of social media as an opportunity to help share. And Colleen, for your presentation around looking at those equity issues, and especially the disadvantaged populations and how stigmatized they become, and how we need to really work with the frontline healthcare professionals and the patients to help share in both directions sensitivities around how do we improve healthcare services so that we can better decrease those inequities and provide services sensitive to the needs of everyone. And the other piece around what you're doing is having tools that you can share with everybody. I think this is being very Canadian. What I hear when I travel internationally is we are very good about sharing and allowing others to gain from our experiences. So thank you. Thank you to all the presenters.
All right, so again, we'll open up the floor for any comments or questions from the audience. And there's one down here.
Thank you. I enjoyed all the presentations, the first set and the second set. As a nurse educator, I'm interested to know how you can share all this across Canada with all faculty so that our students, right, future healthcare workers can benefit from that. And also it reminded me, because a couple of weeks ago I was thinking of writing a letter to the Minister of Health, both provincially from BC and federally, because when clients have to go and see doctors, the appointment times are 10 minutes, right? What can an elderly person or a mom or anyone else can say in 10 minutes? And I had that experience going to see a physician, and then, first of all, the chart was the wrong chart, and said, you are on this medication. I said, no, I'm not. So I got out of my chair. I went to where she was writing and checking. I said, that's not me, right? So there are a lot of errors occurring as well. So I think we need to kind of provide more time for people to express whatever the issues they have. And the system is not designed right now. Some GPs devote more time. There are some GPs, it's only 10 minutes you have with them. How can we provide, right, that opportunity even for people to express what their issues are?
Thank you. Not sure if anyone has a response or, yeah.
I'd love to respond. So what you're expressing is we have 60 years, 70 years worth of literature on when health professionals become patients. After 40 years of having tens of thousands of patients flowing through your hands, it's suddenly a shock and a surprise at what the patient experience is. We've heard so many rich examples this afternoon about involving patients in redesigning healthcare. So I think that's a great reason for hope to change this. In terms of the physician only spending 10 minutes with you, I heard a saying a number of years ago that I've really hung on to, which is doctors should only do what only doctors can do. And I think redefining scope of practice, or at least acting on the scope of practice that we know exists with non-physician health professionals, is a real opportunity. And of course, one of the great barriers is the fee-for-service pay structure. And I think when that's ditched, and I think everyone who's graduating from medical school these days say, I don't want to be a private entrepreneur, I want a different model of compensation. I think we're on the verge of having that happen in Canada. I sure hope so. And I think that will be transformative. So one of the things, the first thing you started out with was how can we share this knowledge? And, you know, the magic of technology allows us to do this. This should be recorded. We should have this posted on UBC Faculty of School of Nursing. It should be available forever. Now, there are issues of consent, there are issues of copyright, but those are things that we can address. And I do a lot of teaching in medical school and in nursing school and to people mid-career across the country. I'm trying to post technology, but I'm not funded. I do all my work as a volunteer. And UBC Medical School has expressed some interest in taking some work I did in Brazil and posting it to be freely available for interprofessional students through the UBC website. So there are ways of using technology to spread the innovation and the brilliance that we've heard today. So yes, we can.
Great. Any question up at the top there?
Thank you. My question is for Jessica directly, and thank you everyone for all of your presentations. They're all wonderful. I'm wondering, Jessica, your group, how do people join the group? How can we in the healthcare system get people involved in the programs that you're running?
So currently it's open to all anyone who kind of walks through the door of Crabtree Corner, and we actually we're in the same house as Sheway. So anyone who's kind of connected to any program in the building, there's 12 housing units, a daycare, so many programs. We're Aboriginal infant development, violence prevention, CAPC, we have lots of food support. So we're getting lots of women in and out of in through the door, and right now that anyone can kind of come along that day. Moving forward, I mean, I think we're open to other locations, but it's pretty easy to just go on a walk. You know, there aren't that like I acknowledge some of the barriers, but I guess hopefully these kinds of things can start out of different centers all over, because that relationship with staff, I think, is really important. So, yeah, is that okay?
When you say anyone can come, are males included? Are they welcome also?
Right. Right. So in March of 2019, we will access the UBC Partnership Grant that will include male caregivers. So there will be one walking group that's safe, that's just for women to keep that kind of safety, and then also to include some of those dads. Yeah.
We have a question up at the back.
Hi, I appreciate everybody's presentations. They were well done. This question is for Jessica. I'm a nurse case manager in the downtown east side, and I love what you're doing. And I look forward to the men's group as well, so I can refer people to it. My question is, after many years walking the streets of the downtown east side as a nurse, I see a lot of pets, so I'm just wondering if you'd be able to integrate pets and dog walking with your groups.
That sounds super cute and really fun. I would love that. I don't have a dog, but I've brought a friend's dog on the group once. Unfortunately, the building isn't a pet-friendly space. But dogs could be outside for sure. I think that's a really lovely idea. Yeah, really, really good idea.
We have time for one or two more questions. Yes.
Sure. Okay. I just have a question for Mario again. I'm just wondering, we've heard sort of the idea of consent and involving patients who might otherwise not be included in research, which traditionally persons living with dementia have been neglected in the research. And I'm just wondering if you could speak